That's why I don't know if I'm
Some people it's just biological, it's like a gene, you know?
I guess so. I don't even know like what her name that partner.
You did all the bottom?
Rachel, she was my partner. She didn't find any calculus. So maybe it's in our team.
You're just like,
Well, I don't know, like I normal time. I was trying to find things, and I was trying to like recipes, but it didn't. So I don't know. And I had my instructor. I was. She didn't tell me anything either. So
yesterday I was crying and nothing.
I can hear her.
You were saying that you had like oh wait, was that? Yeah. Well, I did.
How are you doing, Doctor?
Really, thank you very much.
Do you need a battery? I feel like I have one. Do you feel it like when you talk?
No, actually, it seems to be okay. Yes, thank you.
Yep. Yeah, and it drives me crazy. Like, I floss, and when I floss that spot, it's like breaks. I'm like, oh no. Yeah.
You have a gray hair already.
And then I'm like,
That's wisdom, bro.
Was
it? Alright, I'll leave it in there.
The only wisdom. You're gonna take it out.
You got one wisdom left?
One wisdom left. And you use how much to take it out.
it was in December.
Well, if I look at you, you weren't smart.
Hey, it's okay, it's salt and pepper, alright?
Is your parents like one of your parents?
Or is it, or this is me, yeah.
For real?
Yeah, I started the trend. Yeah. Whatever.
I don't know where I
So how do you feel about your performance yesterday?
He was decent.
Yeah.
I think the hardest part was waiting for Miss Armstrong and have her talk so I think we lost a lot of time. Because every time she went, the only time that I was really off, it wasn't the program.
Oh.
Yeah, it was really off, at least 50%. I mean, it was only one number off, but they consider that okay.
But we don't have a program competency.
No, we already did it.
Oh, okay.
But you know, we want to do it like good.
Yeah. For real. Your brother came all the way from UCLA.
Yeah. Well, he was going, he was on his way, or after that he went to my friends.
Okay, good morning. Sorry, can you hear me in the back? Okay, great. So, we continued blood pain management and different analgesics. We talk about various standard types of analgesics, acetaminophen. We talked about NSAIDs. We talked about opioids. These are the major classes of basically painkillers or analgesic medications. We also talk about the mechanism of action of each, the adverse drug reaction, the major one. Some of them, they had a kind of like maximum daily dose. You have to know that. And also, certain characteristics for each of these classes, like sealing effect versus not sealing effect. Some of them, patient get tolerance to the analgesic effect. Some patient doesn't. And so these are the important things that we need to know. And as you know, this topic in general is one of the topics that you will see a lot in your practice. And you may want to educate your patients about different analgesics. The next one, the topic that we are talking today would be neuropathic pain. So neuropathic pain in nature is a kind of different from nociceptive pain. Nociceptive pain is when we basically induce a trauma. So it's caused by trauma. Of course, the nerve gets damaged too, but it's basically started with a traumatic injury. In neuropathic pain, it's not necessarily the case. So a patient who had a stroke or a patient who had herpes zoster even months ago may suffer from neuropathic pain. So it's basically hypersensitivity of a nerve because of not necessarily trauma. It can be trauma, it can be something else. It can be just the nerve damage, not necessarily the somatic damage. So we call this neuropathic pain. The major types of neuropathic pain could be diabetic neuropathy or post-herpetic neuropathy. Diabetic neuropathy, as you know, a lot of patients with diabetes, either diabetes type 1 or diabetes type 2, eventually they may develop some kind of neuropathy, vasculopathy, and nephropathy. So they may have less sense of pain and pressure, especially in lower extremities. They may have some gastroparesis because of neuropathy, and that's a kind of like diabetic, neuropathy. The other one is post-herpetic. Patient who gets herpes zoster. Patient who had chickenpox when they were younger or kids, and then they have the virus somewhere in spinal ganglia, and when the body is pretty immunocompromised, the virus can come back to the nerve and induce the damage to the peripheral nerve. So it can cause herpes zoster. Then due to the damage, due to recurrence of the damage to the nerve, the patient may suffer neuropathic pain for a longer time. So two populations, patients with diabetes and patients with herpes zoster or after herpes zoster problem. The other type of patients that you may see neuropathic pain are patients with CNS damage. It can be due to surgery prior, like years ago. They had a surgery or accident and they still have neuropathic pain, or patients with a stroke. So the damage was not necessarily traumatic, but it caused the nerve sensitivity or nerve damage. One thing I want you to know about neuropathic pain, which is totally different from somatic pain, or nociceptive pain, is in nociceptive pain we are talking about inflammatory or inflammation kind of pain. In neuropathic pain, it's not necessarily inflammation, because we just talked about that. It's not necessarily due to trauma. So there are other neurotransmitters that we need to address. So let's say if the pain is due to trauma, we may use opioids, and they are very effective. We use NSAIDs, and they are very effective because NSAIDs are anti-inflammatory. We use acetaminophen. We use all of these, and they are effective. In neuropathic pain, these can be used as auxiliary medications, but we also need to cover norepinephrine, serotonin. We need to cover many other neurotransmitters. And in fact, the mechanism behind it is still not that clear. So if you ask me what exactly is the mechanism behind neuropathic pain, there is not clear answer yet. But in medicine, we tried, through the years, tens of years, we tried different medications, different classes of medication, and at this point, we think neuropathic pain is the result of different, the imbalance of different neurotransmitters. So the rest of this discussion is about the medications that we use to reduce the pain based on this theory. Okay, antidepressants. So, of course, when I talk about antidepressants, the first thing come to your mind is we are talking about antidepressants. So if we have a patient with psychological or psychiatric issue or depression, we use these medications. But why we use them in neuropathic pain? Question. Do you have a question?
I was just wanted to make sure that all these medications are gonna be for the neuropathic pain, right?
Yeah, actually, all these medications that we are talking now are for neuropathic pain.
From now on, right?
From now until we end the neuropathic pain. Okay, so basically neuropathic pain, we are not just talking about like typical analgesics. That's the point. You may use antidepressants, totally different class of medication. So why we use antidepressants? Because antidepressants may increase the levels of norepinephrine, may increase the levels of serotonin, and those may basically help to relieve the pain. So initiation of analgesic effect when you give an antidepressant to a patient for neuropathic pain is much faster than the initiation of antidepressant effect. So if you give, let's say for depression purposes, to treat depression, when we start antidepressants, it usually takes a couple weeks to see the results. They start working right away, but to see the results, it usually takes a couple weeks. That's why we have to wait before we think about switching the medication to another one. In regards to neuropathic pain, though, when we give the patient antidepressants, it's usually much faster. It treats the pain much faster than start treating the depression. The other thing about this class is we need lower doses than the doses that we use in depression. So we use the same class of medications, lower doses, and we see the effect much faster. And again, the mechanism of action behind this possibly is due to increase the levels of norepinephrine and serotonin. We think that's the way they work. We are not 100% sure, but these medications are working by increasing the levels of norepinephrine and serotonin. We also may use other medications like anticonvulsants, and I talk about those medications in the next few slides. Okay, let's see. Tricyclic antidepressants are one of the classes that we use for depression. So these are a class of antidepressant agents. We call them tricyclic antidepressant, and the reason for that is a chemical structure is 3 cycles, 3 like benzoic cycles, so we call them tricyclics. So basically, they inhibit norepinephrine and serotonin reuptake. It means they cause the increased level of norepinephrine and serotonin. They potentiate the analgesic effect of opioid, which is good. So if then an opioid is on board and we give the patient tricyclic antidepressant, they help opioids to work. And they also have some sodium channel blocking effects. As you know, whenever we are talking about sodium channel blocking effect, what does it mean?
Gingival ablation?
No. No. Nerve. What about nerve?
It depolarize the nerve. So you can't
Depolarize or?
repolarize the nerve.
Okay, very good. So as you remember, local anesthetics were sodium channel blockers. So if you can block sodium channels on the nerve cells, we basically block the depolarization. So the nerve stays polarized, or in other words, repolarized. So the pain is much less. So these medications have different mechanism of actions. Serotonin reuptake inhibitor, norepinephrine reuptake inhibitor, and sodium channel blocker. So through these mechanisms, they help to relieve the neuropathic pain. Questions? You're tired? Okay.
When it was yesterday, it was exhausting.
Yes, sir. And it's end of the week. So it's normal to be tired. Thursday morning is the worst.
Sorry.
Actually, after this class, right after this, I have a 2-hour meeting. Right after my meeting, I have another 2-hour class. And then right after that, I have another 1-hour meeting. So it's pretty exhausting day for everybody, I think, on campus. Tricyclic antidepressant also has some anticholinergic effects. So whenever a medication has anticholinergic effect, talk about dryness. So they cause urinary retention, they cause constipation, they cause dry mouth or xerostomia, and they cause orthostatic hypotension. So if a medication is anticholinergic, we have like a constellation of adverse drug reaction like this. So if I ask you about adverse drug reaction, please notice. And they also have some other adverse drug reactions. We talked about orthostatic already, cognitive dysfunction, sedation, and weight gain. Okay. In regards to the names for tricyclic antidepressants, I just want you to know the names. Don't worry about which one is more cholinergic, which one is less. Just know the 4 names here: desipramine, nortripdline, amitriptyline, and doxepin. 5 names, and imipramine. So just know the names. And the reason for that is in the exam, you may have a question, which one of the following would be a tricyclic antidepressant? And these are the ones that we use in clinic: desipramine, nortripdline, amitriptyline, doxepin, and imipramine. The ones that you see the most probably in your patients would be either nortripdline or amitriptyline. These are the ones that we see most common in practice.
You said ami and neutral?
Actually, all of the names here. The ones that you see the more common is the triptylines, nortripdline and amitriptyline. Nortripdline on the first line. Okay, not that the rest are not in practice, but less common. The other class of antidepressants are SSRIs and SNRIs. SSRIs are serotonin selective reuptake inhibitor, and SNRIs are serotonin and norepinephrine reuptake inhibitor. What we use more to treat neuropathic pain are SNRIs, because we wanted to target both serotonin and norepinephrine. So SNRI medications are duloxetine, venlafaxine, and desvenlafaxine. These are the medications that you will see many times in your patients, and it can be for different indications. It can be for depression, it can be for bipolar disorder, it can be for anxiety, it can be used for neuropathic pain or fibromyalgia. Okay. Major adverse drug reaction that you may notice would be xerostomia, just like tricyclic antidepressants. These medications also cause xerostomia, dry mouth. And also bruxism. This is new one. And bruxism is an adverse drug reaction which you see more with SSRI, not necessarily SNRI. SSRIs are medications like paroxetine or sertraline. We talk about them later, but for now, just know that you see more bruxism with SNRIs, these medications.
What's
Bruxism is grinding the teeth, like when you recommend your patient to put the night guard? Yeah, night guard. Okay, and also one other major adverse drug reaction, especially with higher doses, would be increase in blood pressure. And the reason for that would be increase in norepinephrine and serotonin levels. So they may cause hypertension, especially with higher doses. So again, please know the adverse drug reaction. Other medications that we may use in neuropathic pain would be anticonvulsants. What's the other name for anticonvulsants? anti-seizure medication. What's the other name for anti-seizure medication? Anticonvulsants, anti-seizure, epileptic, okay. Anti-epileptic medications. So these are the ones like gabapentin, pregabalin, carbamazepine, and oxcarbazepine. So there are no more anti-epileptic medications. There are more anti-epileptic medications, but these are the ones that we use to treat neuropathic pain. So you see, it's very interesting. We use medications to treat neuropathic pain that the major indication is totally different. But we can use them here also. The reason I say this to you is because you may see a patient on carbamazepine and pregabalin, and both medications are anticonvulsants or antiepileptic medications. But the patient does not have seizures. So it doesn't mean that your patient has seizures. You have to be worried about if the patient sees while he or she is on dental seat. So it may be due to totally different indication like neuropathic pain. And this is very, very common, especially with bigger population of elderly recent years. We see more and more neuropathic pain medications, because many of these patients suffer from a stroke or herpes zoster, so they may be on these. Okay, adverse drug reactions. Peripheral edema, ataxia, dizziness, sourness, fatigue, increased appetite, weight gain, and blurred vision. There are many, many other adverse drug reactions also, but these are the ones that are more frequent, or basically the incidence is higher. Also rash, nausea, vomiting, xerostomia, hyponatremia, and SIADH. What is SIADH? Syndrome of, what is I? Inappropriate. ADH. What is ADH? Antidiuretic hormone. So it's syndrome of inappropriate antidiuretic hormone. It means the patient has too much antidiuretic hormone. And what do you think happens if the patient has too much antidiuretic hormone in the serum?
High blood pressure? High blood pressure?
High blood pressure, yes, it can be because the patient has more retention of the water. But more than blood pressure, what do you see? Yes, blood pressure may go up. You're right.
Inflammation?
Not inflammation. There is a serum level of one of the electrolytes that goes low. Which one is that? Sodium. Because when we have more of antidiuretic hormone, it means the sodium gets excreted and the water stays. So that's why the patient gets hyponatremia. So with many of these medications, many of antidepressants or anticonvulsants in general, you will see patients with low sodium. And the reason for that would be SIADH. Okay. And xerostomia and rash. Rash, with some of them, would be pretty significant. That we have to discontinue the medication. So, like carbamazepine, there are some patients that are extremely sensitive to carbamazepine, the third medication, and they get pretty severe rash. So, in those cases, we cannot continue the medication. If it's used for seizures or if it's used for neuropathic pain, for any reason, we have to discontinue. Okay. The next, so we talked about neuropathic pain. In neuropathic pain, which medications use the most? Can you name a couple classes or medications?
For headaches?
Which medications we use the most? Antidepressants? Can you name some of the antidepressants? You're tired today. Let me do this. You know what? When the class is tired, we usually do this. This is better. Because in darkness, everybody goes to sleep. I can see the faces. Okay, so antidepressants. Name a couple antidepressants for me. Doxepin. Somebody said that. Very good. What else? Desipramine. Very good.
I can.
Okay, imipramine. Very good. How about SNRIs? Duloxetine. Very good. Because you see these medications all the time in your patient's profile. Neuropathic pain is pretty common, especially in elderly population. Venlafaxine. How about anticonvulsants? Gabapentin, pregabalin, carbamazepine. So please know the names. Names and adverse drug reactions. We also can use other medications. You know, it doesn't mean that you cannot use acetaminophen or ibuprofen or, let's say, opioids. But the problem is the effect of other medications are not that much. They are not that effective. So these are the mainstay of treatment in patients who suffer neuropathic pain. Okay, let's talk a little bit about headaches and in a specific migraine headache. So in regards to the headaches, if we wanted to just categorize them or classify them, the headache can be migraine with or without aura. So, and the other thing is, the other fact would be it's more common in female patient rather than in male patient. Tension headache, again, if you look at the percentage, it's more common in female rather than male. And cluster headache, about 1% of population. And in cluster headache, like the ratio is the opposite. So it's more common in men than women. But for today, let's focus on migraine, because migraine is a type of headache that we have both prophylactic treatment and abortive treatment for the pain. And you may see both in your patients. So some description about migraine headache. I'm not going to ask these in the exam because the purpose of our exams for the most part is pharmacotherapy or pharmacology. But just for your information, or you may know already, with or without aura, unilateral location, pulsating quality, so aggregation by walking stairs or similar routine physical activity. A lot of patients have nausea and vomiting, photophobia, and phonophobia when they have migraine attacks.
What's NV?
Which one?
NV?
Oh, nausea and vomiting. NV is nausea and vomiting. Okay, so this part is very important for us to know. Sometimes we need to give the patient the medication that prevents migraine headache, not just wait for patient to have headache and then start the medication. Because a lot of times it's too late. The patient suffers vomiting, nausea, headache for 2 or 3 days, and it's not good. So in order to prevent that, we need to give the patient routine daily medication, and basically we see if the patient has any of these characteristics. Recurrent migraines and the migraine interfere with the daily routine life. So if this is the problem, then you think about giving the patient prophylaxis. Patient experiences inefficacy of acute treatment and adverse drug reaction of acute treatment. So, if the patient cannot tolerate migraine because it affects his or her daily routine life, that's one of the indications to give prophylactic regimen. The other thing would be if the patient cannot tolerate the acute medication because of adverse drug reaction. We have very good medications for acute pain, acute migraine pain. But the problem is, for some patients, they may be contraindicated. And I talk about that in a few minutes. Okay. Don't worry about the last bullet, the regimen. Just know the first part. Prophylaxis in the following condition. That can be a good question. So which patient population you give, or why you even think about prophylactic regimen? Because it's not appropriate for everybody necessarily. These are the prophylactic options for migraine. And unfortunately, you have to know all, because these are not all, these are some of them, but these are the ones that we use most commonly when we are talking about prophylaxis of migraine. By that, I mean that we give the patient metoprolol on daily basis to prevent migraine attack. It's not PRN. It's not as needed anymore. Okay? Because for pain, we usually give the patient PRN as needed medication. But to prevent migraine, we have to give them routinely, either daily or twice daily. It depends on the medication. So let me ask you, what are the first two medications? Beta blockers. So you see the indication is totally different. You're talking about beta blockers. Where did you see beta blockers in the past? Asthma? No, not in asthma. Hypertension or tachycardia. So we use these medications for hypertension and tachycardia, but there is another indication for them, and that's prophylaxis of migraine headache. Valproic acid is, do you know by any chance what is valproic acid? Okay, we talk about that later, not this session, but later. It's another anticonvulsant. So it's another antiepilieptic medication. It's also maybe used in bipolar disorder, sometimes in depression. We use valproic acid also. So different indications, but major use would be for like patients in epilepsy, with epilepsy. The other medication is topiramate. Topiramate is another anticonvulsant. So you see medications with totally different indications, but we use them to prevent migraine headache. So valproic acid and topiramate are anticonvulsants. Timolol. What is timolol? Beta blocker. So even if you don't know timolol, just by knowing olol, it's a beta blocker. So what would be the effect of timolol on the heart rate?
Decrease it.
Very good. Decrease it. Very good. Amitriptyline. What is amitriptyline? Very good. Tricyclic antidepressants. Thank you. So this is an antidepressant medication, but we use it to prevent migraine. Atenolol, beta blocker, very good. And venlafaxine, SNRI. So it's an antidepressant and it's an SNRI. So please know the medications. And again, these are not for abortive pain management. These are not for acute pain. These are to prevent the migraine attack. Okay? Do you know any patient to use these medications? Any of them? No? Okay. You will know in future. Your patients. So if you see a patient on metoprolol or propranolol, it's not necessarily means that the patient has hypertension or tachycardia. It can be totally different thing that is like prophylaxis of migraine. Okay, now let's talk about acute pain management. Let's say the patient was on these medications or was not on these medications, but for any reason now the patient has acute migraine pain. In the past, we just used NSAIDs, aspirin, acetaminophen, caffeine, something like Excedrin, and still Excedrin migraine may work on many patients. But they are some classes of medications that are much more effective to treat acute pain. And these are triptans. Triptans are serotonin agonists. It means they bind to serotonin receptors in blood vessels, especially in blood vessels in the CNS, and they cause vasoconstriction. And with that mechanism of action, they reduce the acute pain of migraine. So for the exam purposes or for practice purposes, when you see these medications, these are only PRN. These are only as needed. So the patient never take triptans routinely or on daily basis. By the way, 5-HT is serotonin. That's an acronym for serotonin. 5-hydroxytryptamine is serotonin. So in some of the texts, you may see 5-HT instead of the word serotonin. Okay, with what I just said, what do you think would be the major adverse drug reaction of triptans? Hypertension, high blood pressure. So which patients would you think it can be contraindication? Patients with hypertension or patients who are on antihypertensive medication and still have no good control on blood pressure. So in those patients, we have to be very careful to put the patient on triptan. Because after every dose of treatment, the triptan, the patient may have higher blood pressure. A good thing about these medications is, usually, if the patient gets migraine pain attack, it takes 1 or 2 doses for the relief. That's a good thing about these medications. These are very effective medications. 1 or 2 doses, usually. So that's a good thing. But again, some patients are very sensitive in regards to vasoconstriction. So even with 1 dose, they may have a spike in blood pressure, and they cannot tolerate it.
I have a question. So what are you missing in your body when you have migraine? Like, is there any electrolytes? Or is it
Okay. The pathophysiology behind migraine is basically recurrent vasodilation and vasoconstriction in the brain. So mostly it gets started with vasoconstriction, then the body wanted to balance that and basically release neurotransmitters to cause vasodilation. Then during the vasodilation time, the patient feels more pressure and pain. So that's why we use these medications to constrict the blood vessel again. So that's basically like vasoconstriction, vasodilation, and this is a kind of like irregularity of those events in patients. Okay, medications. Medications are all end with triptan. So if you see any medication with triptan, it's used for acute migraine pain. Have you ever heard of any of these, either brand or generic name? Imitrex. Imitrex was one of the first ones. Zomic, Maxalt, and others. Extremely effective class. Extremely effective. You know, for the ones who have a friend or family member with migraine, you probably know after a dose or 2, the patient gets a good relief, usually. Okay, there are a couple points that you need to know, and the reason for that is, I will ask you when we go over that. Sumatriptan, look at the dosage forms. Sumatriptan, first of all, the patient can take the tablet. Okay, so that's good. If the patient can take the tablet, that's the best way. It also is available as subcutaneous or intranasal spray. What's the advantage for that? Fast, no, not vasodilation. Yeah, faster effect, but besides faster effect, what would be the big advantage for this medication in a migraine patient? No gastric ADRs. Okay, it's made, even the PO one doesn't have gastric ADR, so it doesn't cause gastric upset. But something about gastric. Something about GI.
They don't have to drink it.
Oh, it's destroyed. GI.
Many patients with migraine, they have what?
Oh, vomiting.
Yes, they have nausea and vomiting. So if the patient is in acute migraine attack, they may vomit. So they cannot tolerate the PO medication. So it's a very big advantage of the medication for this specific indication to be available in other dosage form. So the patient can spray intranasally or inject subcutaneous, and it's self-injection. So the patient can do that, and it's easy injection. It's just an education for them. And I just put that there. Sorry, I didn't pay attention. I put for patients with nausea and vomiting. Okay. Zolmitriptan has also intranasal in addition to PO. So zolmitriptan is another triptan besides sumatriptan that has intranasal form. So it's good. And the reason I say that is in the exam I may ask which of the following medication has advantage in patients with nausea and vomiting. So you want to choose the ones that the patient can use intranasally or with injection. Is that right? Okay.
Nausea or what?
Or vomiting. Rizatriptan and zolmitriptan has also orally disintegrating tablets. It means if the patient cannot drink or cannot tolerate drinking water, the patient can just put that in the mouth and it just gets disintegrated. That's good again. So pharmaceutical companies expend a lot of money to come with these dosage forms for the patients who cannot tolerate the regular tablet or capsule or syrup, which is good. Okay, so please know this specific information about some of the triptans. But in regards to the names, these are all the names. Major adverse drug reaction, again, the major one would be hypertension because of vasoconstriction. Okay, let's see. Okay, triptans are contraindicated in uncontrolled hypertension, in pregnancy, in ischemic bowel disease, and in peripheral vascular disease. So in any of these situations, triptans are contraindicated. Use with caution in patients on antihypertensive medication. We just talked about that because those patients probably suffer from hypertension. Use with caution with patients on serotonergic medications like SSRIs and SNRIs. What's that? Why we say that? Why, if the patient is on venlafaxine, you want to be very careful to put the patient on a triptan?
Because it works on the serotonin.
Very good, because both medication works on serotonin. Both medication increase serotonin level. So both medications together may cause more hypertension, more severe hypertension. So we have to be very careful about that. So please know all these conditions. Contraindications, especially the first bullet, contraindications. Okay, I'm not going to ask anything about this slide. These are just for your information, but especially the very first bullet is interesting because it's a combination of sumatriptan with what? An NSAID. So it helps because in the past, NSAIDs were the only medication that we used to use for migraine. And there are some combinations. And what it tells you, besides that we have a combination medication like this, what it tells you. Let's say the patient has sumatriptan or amitriptyline or injection at home. So the easy thing is, if the patient just go and get a bottle of naproxen, it's OTC, then the patient has automatically the combination. So the patient doesn't need to go and buy the combination medication, which is very expensive. Sometimes a part of that is over the counter. They can go and get it on their own. Okay. Don't worry about the second bullet, not to exceed daily dose. Ergotamine is another medication that, especially in the past, we used it, and now still it's in clinical use. Not as frequent as triptans, but ergotamine also causes vasoconstriction. So in regards to acute pain management, it can be an option. So what would be the big precautions about this? If the patient is on ergotamine, you probably don't want to give the patient triptan at the same time, because they both cause hypertension again. Okay, on this one, talking about adverse drug reaction and possibly contraindications, the same contraindications that we had with triptans. And there are some dosage forms of ergotamine that also are intranasal or injection. So for patients who have nausea and vomiting with headache, we can use them. NSAIDs can also be used in combination with triptans or in combination with acetaminophen, with caffeine, if the patient is not sensitive to caffeine. Because some patients, if they get caffeine, it's a kind of like trigger for their migraine pain. So it depends on the patient. Some get better results, some they don't want to have caffeine in combination. And the last slide would be other medications that we may use. These medications are not necessarily controlling the pain. These medications are given to the patient to control nausea and vomiting. Prochlorperazine, metoclopramide, and chlorpromazine. These are all anticholinergic, antihistamine, antidopaminergic. So they are old, very, very old medications. Questions?
When you say caffeine, like a caffeine pill or like a cup of coffee?
Either way, either or. So the question is, when we are talking about caffeine in migraine patient, are we talking about caffeine pill, like in Excedrin? There is a very small percentage of caffeine, or a cup of coffee, either or. Some patients with migraine are even very sensitive to the smell of coffee. So it can be a trigger for them. Okay, so this last slide is only to control nausea and vomiting. Okay, great. Any questions? Do you want to have a 10-minute break?
Yes.
Good. So if you have a 10-minute break now, please come back at 5 to 9. Okay, thank you.
No, it's not even like correct.
Did you see our my brother and sister do want to go on no, it's like this conversation. Oh.
They always want to get on like,
Yeah.
very study all the book questions.
Oh, yeah, I looked over. Oh, you know.
You have to be like, yeah.
The whole shop? Not this.
The questions was like, I told me that online.
Oh, you're right. So,
How do I get to it? Take advantage of the work.
yeah.
Right. I know, but like, not too really smart. So, like the bros versus big order. Yeah, and then since I have the tendency to get away from those, I can get. But when someone like my like the same body, like body type, it's a good competition because I can't do anything. I'm like, did you watch it?
I do it all the time.
What was that though? I think it's also a few lectures.
Did you record this one?
Yeah.
Oh, I changed it.
Just like once you're back from lunch.
Yeah, I have no idea. I thought she just like was talking about our
Pretty good.
Yeah.
What's your favorite food?
My favorite?
I was gonna bring He was like, wait, I have to be here at 4:30. And like, Christina didn't tell you how long the appointment was. He's like, no. But he didn't eat lunch. He hadn't eaten lunch, so that's why he thought that it would be like an hour or something. And he's go. And I kind of wanted to like drop that.
But it's like,
Yeah, I was like.
these are a lot of sugar. Yeah, very sweet taste. But they have a thing called a tea leaf salad.
Of the book? Is there two versions? Is this the old one? I didn't even know there was two different.
Yeah, it's good. Are you really like
Is your base at Slam?
there's
I started there. No, I started at the top of the words. After the questions, I just started after the questions. Because she always, whenever she has page numbers, it's always like the middle of the page. Really? Yeah, it's always like that. Not those questions, because we didn't read the material before. Yeah.
Oh, you like
Yeah. Thanks. I wanted to layer it.
okay.
She can't watch this.
Quick question. You said for ergotamine, is it ADR is hypertension?
Yes,
Okay.
yes, because it causes vasoconstriction.
Okay. Yeah. And also, how come no one really understands the mechanism of
Neuropathic pain.
yeah?
Oh, you know, because the thing is, there are many neurotransmitters possibly involved in neuropathic pain, and that's the reason, because we don't know exactly which one is more important, so we target many different ones. So we target norepinephrine, serotonin, sodium channel blocker, so
What about, I know because over the counter, one of my friends, he takes 5-HTP. What exactly is that? 'Cause I know like it's supposed to be relaxing and stuff.
yeah. Oh, okay. So
Because I know on the thing, when you said 5-HT, but then I know in the store, OTC, they sell 5-HTP.
yes. So maybe there are some supplements of serotonin. I honestly don't know the efficacy of those. We don't use them as real treatment options. Supplement, it may help.
Okay,
Who
yeah.
knows? Maybe it's okay.
All natural.
Yeah. But if it's 5-HT, is that right? 5-HT?
It's this. It's 5-HTP. 5-hydroxytryptophan.
It's not exactly serotonin, it's because serotonin is 5-hydroxytryptamine. So this is 5-hydroxytryptophan.
Yeah, and they sell this OTC, and then my friend takes it. And he's like, yeah,
I don't know. You know, in regards to supplements like this, I have no idea.
oh,
Yeah. But it's good that he thinks it's good.
yeah, well, it says on the bottle, it says helps with calming you and relaxing you, whatever.
Yeah. Chamomile tea.
Exactly. Chamomile tea. And so when someone's taking like antidepressants, how like okay, so they would have to go to a doctor or like psychologist and have them like what if they have like multiple disorders and then take different medications?
So the physician needs to know. So yeah, exactly. So they do not duplicate the medication. So if the patient is suffering from depression and also neuropathic pain, maybe like venlafaxine works. So the patient doesn't need to be on venlafaxine for one and another antidepressants for another one.
I forgot which one it was, but I remember on some medications on the back, like over the counter, it says do not take with serotonin reuptake inhibitors. I forgot which one they were. I don't know if like acetaminophen or...
No, it's not acetaminophen. It's like NSAIDs.
Oh yeah.
Yeah. You know, it's not contraindicated. The only thing is, if you get ibuprofen or naproxen or aspirin with SSRIs like antidepressants, the risk of bleeding may go higher, but it's not contraindication. I mean, as long as the patient is not overtly use one, that's fine.
So a person has like pain or somewhere, and they take like aspirin on top of their antidepressants.
That should be fine. That should be fine. If there is a bleeding, then we have to think about antidepressants. But if it doesn't occur, that should be fine.
I was also going to ask you, doesn't, I forgot which slide it was, you said that by taking antidepressants, it will potentially have analgesic effect of opioids. Wouldn't that increase dependency of the opioids?
No, increase the effect, not the dependency.
No, I know, it would increase the effects of what if the person get like...
No, it increases the effect of analgesic, like analgesic effect.
You got instrumentation today or no?
Yeah, just for the pain.
Oh yeah. So I got it. You have it? Yeah, 1 to 3.
No. It just
I just want to go home.
help to relieve the pain. Yeah.
Yeah, seriously, man. Thank you.
You're welcome.
Sure. How are you?
Hi.
Good. Quick question. I don't know to recommend like medication, like I've been coughing. Are you able to recommend like an over-the-counter medication for no, so I've been coughing a lot.
Oh, I see. Okay.
Yeah, I've been coughing. I went to the the doctor here, and they gave me fluticasone for like a nasal spray and Allegra. I've been taking that for like 3 days, and it has my cough hasn't gone away. I've been like coughing.
Do you think the cough is due to the postnasal discharge?
That's what they said, postnasal drip. The doctor said that.
Okay.
But I've been expulsurating as well.
Okay.
Less, but still.
I see.
But still, I have like that phlegm tighter. I don't know. I called them to see if I can see them, but they don't have an appointment until Monday.
Okay.
I can go to the urgent care, but I don't know. When I went to get the medications, the pharmacist there told me to take albuterol, but that would be.
Albuterol is if you also have like
wheezing.
discomfort or wheezing, or if you cannot breathe well, you have that.
No, I can breathe right.
No, I think probably your cough is due to like postnasal like drips. So continue that postnasal. Yeah. The thing is, with 2 days is not enough.
Okay.
So you have to keep using that.
Okay.
Also, keep taking.
I took the Tussin. Remember how I showed you the Tussin? But I took that like a week ago.
It's still there.
What happened?
It's still there. The cough is still there.
It's still there.
It takes time.
It takes time.
It takes time. But Allegra is good. Fluticasone is good. So keep taking that.
Keep taking that.
Yeah. And
and they also give me pseudoephedrine.
Pseudoephedrine, if you have a lot of congestion, so I don't see any.
Just stop that then?
If you don't have congestion,
I don't have.
like nasal congestion, sinus, okay, so don't worry about pseudoephedrine.
So just stop taking that.
Yeah.
And then keep on taking fluticasone
And Allegra.
Yeah, because last night I couldn't stop coughing the whole night, and I was like, oh wow.
No, actually, it's unfortunately sometimes after cold or after some kind
I
of.
was sick, but that was like during finals. I was sick.
I know. My colleagues got cold and they still cough.
And there's like a bad cough, cold season, like. But I don't know. I'm kind of getting annoyed of like. Oh,
No.
So just keep on taking that.
Yeah, keep taking those and guaifenesin or robitussin.
Robitussin.
Yeah,
Keep on taking that.
take that. It helps.
Okay.
And a lot of fluids.
No, yeah, I've been a lot of water and all that stuff.
Yeah.
So. Okay. All right.
No, it gets better.
Okay.
It just takes time.
Yeah. All right. Thank you, sir.
Yesterday and today, and I was like, it's so weird, you know? Like, you guys were all just like, that's just weird.
I think we're like all of these
Okay, let's start the second topic today. So totally, let's change the topic to anticoagulation. Again, this would be a pretty important topic for you because you may have patients due to cardiovascular diseases, due to like a history of blood clot, like DVT or PE, like thromboembolic event. They may be on one of the anticoagulants or antiplatelet agents, and it's important for you to know the medications. So to identify those medications and know that those may increase the risk of bleeding. Does it mean that if you have a patient on any of these medications, you cannot perform the dental or dental hygiene procedure? No, not necessarily. You just want to know that the patient has increased risk of bleeding, so you may educate the patient to avoid like things after the procedure that may cause bleeding. So there is no contraindication of being on these and have a dental procedure. Okay, so first of all, when we use anticoagulants, we use anticoagulants to prevent the formation of clot. So that's number one, prevent the formation. Number two indication is to keep the existing clot not becoming larger. So if there is a clot, at least not becoming larger. So when we use anticoagulants, they do not dissolve the clot. So if the clot is there, it's there. They are another class of medications that if the patient has a clot in the brain, a blood clot in the brain, we can give that medication, and that medication dissolve the clot. And those are only used in hospital, in cardiovascular emergency units of the hospitals. We cannot give them to the patients, and we cannot use them in the office. But if the clot is already there, we give anticoagulants to prevent the enlargement of that clot, or if the clot is not there, but we expect the clot to be formed, we give anticoagulants to prevent the formation of the clot. Okay, so indications in medicine would be treatment or prophylaxis against deep vein thrombosis, DVT, or pulmonary embolism, PE, or if the patient has atrial fibrillation, we may want to put the patient on anticoagulants to prevent a stroke. Because if the patient has atrial fibrillation, it means the heart is not pumping well. The heart has just fibrillation. So there is a big chance, or there is a big risk to form a clot in the atrium, and then eventually it goes to ventricle and gets sent to the brain or other parts of the body and causes a stroke and other sequelae that are not good. So in order to prevent that, we put the patient on anticoagulants. Just as a reminder, when we are talking about coagulation cascade, we are talking about intrinsic, extrinsic pathway. I'm not going to ask about this. I just wanted to just remember some of the important factors in regards to coagulation. One of the very important factors is factor 10. In the middle, when extrinsic and intrinsic pathway get together, they get to factor 10. So if factor 10 is very important for coagulation, and if we want to prevent coagulation, if we can develop a medication that blocks factor 10, it's very effective. Is that right? Because factor 10 is one of the key factors for coagulation. So if we have a medication that is anti-factor 10, it's a very good anticoagulant. Is it right?
Yes.
Okay. The other important factor is thrombin. Thrombin is which factor? Which number? Just give a number.
10.
No, 10 is right there.
11.
11, good. No. Lower. 1. I don't know if you have factor 1. 2. Who said 2? Very good. Yeah. So thrombin is factor 2. So if you have a medication that blocks factor 10, or if we have medications that block factor 2, we can prevent coagulation. Okay? So other factors are also important, like factor 7, factor 9, factor 11, possibly. But I don't know, I don't say factor 11. I don't know if factor 11 is important in coagulation. But for sure, factor 2, 7, 9, 10 are very important. Specifically factor 10 and factor 2. I don't know what's the name for factor 10. I don't think there is any specific name for factor 10, but definitely factor 2 is thrombin. So we call those medications anti-factor 2 or anti-thrombin agents. Okay, and at the end, the thrombin basically activates the fibrinogen to be fibrin, and fibrin causes the blood clot. So this is not a bad thing. Coagulation is very important to prevent bleeding. But the problem is, in some patients, we have hyperactivity of this cascade. So without any reason, the patient starts to have all these reactions. And there is one blood clot or a couple blood clots in different parts of the body, and that causes ischemic events for some organs, which is not good. Okay, so the first medication, and one of the oldest anticoagulant agents would be unfractionated heparin, or heparin. You know, the heparin that you heard the name a lot, the other name for that is unfractionated. And why we call it unfractionated? Because it's the whole molecule of heparin. So, unfractionated heparin, or UFH, or heparin. So in the exam, I may ask any of these. So if you see an acronym, the acronym is here. You need to know that. Indications are again the same: DVT prophylaxis, treatment of DVT. So if the clot is formed and we want to treat it, the patient already has DVT, we can give the patient heparin. Treatment of patients after MI, after heart attack. And another very important information about heparin is if we wanted to monitor the efficacy and also monitor the toxicity. We wanted to make sure the patient is not toxic, not too much heparin, not too low heparin. We monitor APTT, which is a coagulation marker in the blood. So the higher the APTT number, it means the blood is thinner. So APTT is low. After we start heparin, after a few hours, the APTT start rising. So the increased level of APTT means the patient has thinner blood. Another very important information, in general, let me tell you, for this section of our lecture today, almost every single slide is at least 2 questions. So I try to just shrink, concise the whole thing in these slides. There are 25, 26 slides. But we have a good 1 or 2 questions in each slide. Antidote for heparin is protamine. So let's say if your patient is accidentally overdosed by heparin, or if the patient is on heparin and the patient has bleeding, or the patient has emergency surgery that we want to reverse heparin, we can give the patient protamine. Okay, so that's an antidote. Half-life. The half-life of heparin is 1.5 hours, an hour and a half, which is very short compared to other anticoagulants. Do you think it's good or bad? Good. It can be very good. For the most part, it's good. And the reason for that is if you need to reverse, you just stop the medication. That's a good thing. Because if you have a patient and the patient needs to have a surgery today, you can stop heparin and do the surgery in the afternoon. Okay, or dental surgery or medical procedure. The problem with heparin is it's injectable only. So the patient cannot take it orally. So to put that a patient on long-term heparin, first of all, injections every day, 2 or 3 times a day, it's not easy for patient. For a couple months, a few months, maybe okay, but not for long term. And there are some adverse effects that I talk about. So an advantage of this medication, always remember, short half-life. Whenever you need to stop it and do the procedure in a few hours. Renal dose adjustment with heparin, another big advantage is you do not need to adjust the dose for patients with poor renal function. So if your patient has excellent renal function, a young 20, 30-year-old patient, that's good. If you have a 9-year-old patient, it's still good. If you have a patient on hemodialysis, it's still good. So you don't need to adjust the dose. So that's another big advantage of this medication. And I mentioned about antidote, protamine. Regarding the dosing of protamine, each 1 milligram of protamine reverses 100 units of heparin. Each 1 milligram reverses 100 units of heparin. So if I want to reverse 300 units, how many milligrams I need? 3. Okay? The other fact about protamine is the max dose is 50 milligrams. So how much heparin it can reverse? 5,000. And that's enough. Because with the dosing, it's enough for a patient to reverse the heparin for the whole 24 hours. So each 1 milligram of protamine represents 100 units of heparin. Heparin unit is units, not milligram or microgram. We said unit. And then the max dose of protamine is 50. And that could be a very nice board question. Adverse drug reactions, hyperkalemia. That's interesting. Heparin causes hyperkalemia because it has some anti-aldosterone-like activities. So it's totally irrelevant from its mechanism of action that we use as anticoagulant, but it may cause hyperkalemia. So if you have a patient, especially with higher doses of heparin, the patient may have high potassium level. Bleeding, of course. Just like antihypertensive medication, one of the major adverse effects would be hypotension. With anticoagulants, one of the major adverse drug reactions would be bleeding because the blood is thinner now. So the patient is at higher risk of bleeding. Another major adverse drug reaction, especially with long-term use. I'm not talking about a week use of heparin or 2 weeks. For long-term use, it means for patients who need to be on heparin for months would be osteoporosis. So heparin goes to the bones and causes bone resorption. So if the patient needs to be on heparin, some patients, due to genetic disorders, they form blood clots very often. So if the physicians put them on heparin, unfortunately, one of the adverse effects would be osteoporosis. And another major and emergency adverse drug reaction besides the bleeding would be heparin-induced thrombocytopenia. Some patients are very sensitive, genetically are sensitive to heparin. So as they receive heparin, they start to have antibodies against the molecule. And the next time when we give them heparin, then it causes the platelets to clot together, or platelets to aggregate together. So it causes heparin-induced thrombocytopenia. So the platelet thrombocytopenia, because there are not active platelets anymore, so the platelet counts go low. But in fact, all platelets are aggregated together. Is it good or bad? This is bad, because that's another clot by itself. Because you have masses, big masses of platelets in different parts of the body. They are not functioning, they just obstruct the blood flow. Something like this, but in different parts of the body. So if the patient is on heparin and after a few days or after a week, we see a big drop in platelet count, it's not good. It means patient probably developed HIT or heparin-induced thrombocytopenia. What we need to do is immediately stop heparin and start the patient on other medications, other anticoagulants. But the key point is no heparin anymore and never. If the patient developed HIT one time, we cannot use heparin at any point. And it's not rare. I mean, HIT, unfortunately, in patients who come to the hospital for surgeries like orthopedic surgeries or cardiovascular surgeries, the percentage, just look at the percentage. In orthopedic surgery, we have 15% of HIT development. In cardiovascular surgeries, we have 50%. So surgical patients, we put them on heparin afterward to prevent DVT or PE while they're in hospital, and then they develop HIT, some of them. So we have to be very careful about platelet count. Okay. Next medication is low molecular weight heparin. So the first one was the whole heparin molecule, unfractionated heparin. This one is a smaller. So we cut the molecule to a smaller one, because this smaller one is enough to block factor 10. Heparin blocks factor 10, factor 2, a lot of other factors. But low molecular weight heparin, for the most part, blocks factor 10, and that's enough to induce anticoagulation. The medication I want you to know, in this class, there are 3 or 4 medications, but for you, please know enoxaparin. And the reason for that is, in the US, for the most part, we use enoxaparin. Among all low molecular weight heparins that are available in the world, we use enoxaparin here in the US. Indications pretty much the same as heparin, like for prophylaxis of DVT or PE or for treatment. Half-life, look at the half-life, 5 hours. Is it longer or shorter than heparin? Longer. So do you think it's good or bad, or not necessarily good or bad?
Could be good or bad. Depends, right?
Very good, depends. It can be good or bad. It's bad because if we stop the medication, it doesn't mean we have the reverse immediately. It takes longer. So if you have a patient on Lovenox or enoxaparin and you wanted to perform a surgery, emergency surgery, if you stop the medication, at least for half a day, you have to wait until perform the medication. But another thing is less frequent injection may be needed, which is good. So for heparin, we may want to inject 3 times a day. For Lovenox, once a day would be enough. So that's the advantage and disadvantages about the half-life.
Bupropion would be still the antidote?
Yes, we get to that part. So the half-life is 5 hours. Then in regards to renal dose adjustment, yes, you need to adjust the dose for patients who have poor renal function. Is it a good thing or bad thing? It's bad. For sure it's bad. Heparin, a big advantage of that was we don't care about renal function. You still can give heparin and you don't need to adjust the dose. For low molecular weight heparin, you have to reduce the dose if the patient renal function is poor. Still, it's injectable only. So heparin and low molecular weight heparin, they are only injectable. We have no PO form. We have no oral form of them. So it's self-injection, so the patient just injects it on belly area for the most part. It's pretty easy injection. The volume is low. The needle is pretty thin and short, so the patient can do that. Adverse drug reactions, bleeding, HIT again, because it's still heparin, but it's smaller molecule. So patient may suffer from HIT, but the percentage or the incidence is lower than heparin. Injection site reaction, just like any other injectable medication, it may cause bruising, but in addition to that, since these medications are anticoagulants, the bruising may be bigger. Hyperkalemia again, just like heparin, enoxaparin can cause hyperkalemia, and antidote is protamine again. So that's a good thing. You can use the same agent as antidote. In this case, each 1 milligram of protamine reverses 0.5 to 1 milligram of enoxaparin. So here you see the units are different. In heparin, we had 100 units. In low molecular weight heparin, just think this way, 1 to 1. Make it easier. Each 1 milligram protamine may reverse 1 milligram of enoxaparin. Since the needle is very short and thin, a 90-degree injection is good for sub-Q injection. So the patient doesn't need to go with 45 degree. 90 degree is good enough to go to sub-Q tissue. And unfortunately, it may cause bruises, and if the patient administer it in other parts, like on the arm or thighs, the bruises may be much bigger. So belly part is the best area to inject heparin or low molecular weight heparin. Okay. Now let's talk about oral agents. Oral agents, for the most part, especially the newer agents, the one that when you go to the practice you may see the most, are either anti-factor 2 or anti-factor 10. Okay, so they are either antithrombin agents or anti-factor 10 agents. The majority of them are anti-factor 10 agents, the new agents. And they came to the market in the last 5 or 6 years. So before that, we didn't have these agents. So in the past 5 or 6 years, we have all these medications came to the market, at least 5 medications, and they are all good, and they are either anti-factor 10 or factor 2. So the first one is rivaroxaban. Don't worry about the brand name, just know the generic name. Whenever you see the medication ends with axaban, do you remember XA was factor 10. Ban is to banning that. So it's anti-factor 10. So rivaroxaban is anti-factor 10. Do you need to adjust the dose for renal function or renal insufficiency? Yes, you need to adjust the dose. If the renal function is very severe, it's contraindicated to use rivaroxaban. These are all good questions. There is an FDA-approved antidote, extremely expensive. It just came to the market a few months ago. These medications are all new. The antidote just came to the market, andexanet alpha. But it's good because it's antidote. So if you have too much of the rivaroxaban in the system, the patient is bleeding, you want to reverse, you can give andexanet. Next medication is Eliquis. Have you heard about Eliquis in TV commercial? So the generic name is apixaban. Another Axaban. So it's anti-factor 10 again. These are all PO. Patient takes the tablet. Renal dose adjustment, yes, it's necessary. So far, what was the only medication that you do not need to dose adjust for renal function? Heparin. Rather than that, all other medications that we are talking about, they need renal dose adjustment. So for apixaban, is if the patient is old or older than 80, if the patient has poor renal function, or if the patient weight is less than 60 kilo, and you don't need to know them because I didn't mention them here, but it's based on patient weight, patient age, and renal function, we need to adjust the dose because we don't want too much medication on the system. One big advantage about apixaban is if the patient is on hemodialysis, we can use it. Because in other axabans, if the patient has poor renal function, then the patient is on hemodialysis, we cannot use them. Apixaban is the only axaban that we can use if the patient is on hemodialysis. Look at the half-life, 12 hours. It's much longer. Heparin was 1.5, enoxaparin was 5. Apixaban is 12 hours. So it's much longer. It's good because the patient can take 1 pill or 2 pills per day and the patient is fine. It's bad because if you need to stop the medication and do the invasive surgery, you have to wait at least for a day or two. So there are some advantages and some disadvantages with that. Is there any antidote? Yes. Again, the most recent FDA-approved antidote, andexanet, is also effective for apixaban. So if the patient has overdose, if the patient has bleeding, or we need to perform the surgery right now, we can use andexanet. Okay, and the last part, no monitoring for efficacy is required. For heparin, we check APTT. Later, we talk about warfarin and we check about the marker that we have to check for efficacy. For axabans, you do not need to check anything. So for rivaroxaban, look at the last bullet. And for apixaban, you do not need to monitor anything in the blood. Next medication is doxepin. Again, it's anti-factor 10, axaban. Okay? There is a unique characteristic for this medication, and I only heard that for this medication, not any other medication. And that's the fact that if the patient has very good renal function, this medication shouldn't be used. So in a young, healthy patient with a perfect renal function, we cannot use a doxepin. And the reason for that is if the patient has a good renal function, the patient clears the medication very fast, and it's not effective. So the patient needs to have bad renal function, or not very good renal function at least. So it makes the medication not a favorite choice because of this fact. And also, on the other side, if the patient renal function is poor, you have to adjust the dose again. So it's not very good for patients with good renal functions or for bad renal functions. The patient needs to be in the mid-range. Let's see. Okay, another disadvantage for edoxaban. Poor company who made this medication. So, another disadvantage is there is no FDA-approved antidote. So if the patient has overdosed on this, there is no antidote. So why do you want to use this?
That's the question.
That's the question. I don't know. It's in the market, but I never saw that as being prescribed. You know, each medication, before it comes to the market, before it gets FDA approval, it takes millions, hundreds of millions of dollars. It's not easy to develop a medication. So when it comes to the market, it's very hard to withdraw it from the market. So maybe that's why we see that as an approved medication. Okay, let's talk about anti-factor 2 inhibitors. Another name for them would be antithrombin. The only oral medication for factor 2 to inhibit factor 2 is dabigatran. So dabigatran is the only oral anti-factor 2. Renal dose adjustment needed? Yes. If the patient renal function is not good, we have to adjust the dose. We have to decrease the dose. And if the renal function is very low, you have to discontinue. FDA approved antidote? Yes, that's good. Idarosuzumab is the FDA approved antidote. So that's a good thing. It's extremely expensive, but if we have to use it, if the patient is bleeding, at least we have an antidote. And again, no monitoring is needed. So we don't have to check blood, INR, or PTT, anything like that. The last oral anticoagulants that was one of the most famous, like the mainstay of anticoagulant medications for years and years was warfarin. Not anymore. These days we see more and more patients, more and more cardiologists are switching patients from warfarin to the newer agents that we just talked about. Because those patients, the patient doesn't need to do the lab work, they don't need to monitor anything, and they're pretty good. They work very well. There are a few patients that need to be on warfarin because of mechanical valve or other issues. So warfarin in general is vitamin K antagonist. So in the liver, vitamin K has a very important role to turn factor 2, 7, 9, and 10 to their activated forms. So they are synthesized, but they are inactive. In order to be active, vitamin K needs to be there. If the patient takes warfarin, warfarin antagonizes vitamin K. So there are factor 2, 7, 9, and 10, but they are not active. Okay?
So vitamin K activates them?
Yes, vitamin K activates them. So if you use a vitamin K antagonist like warfarin, those factors are there, but they're not working. So that blood gets thinner. Okay? So the generic name is warfarin. The major brand name, there are different brand names, but the major one is Coumadin. So your patient may tell you, I'm on Coumadin, the same thing. Indications for atrial fibrillation, treatment of VTE or DVT, or if the patient has mechanical valve, this is one of the only medications, oral medications that the patient can take. One important thing about warfarin is you need to monitor INR. That's when INR gets important. And the higher the INR means the blood is thinner. So if the INR is 3, it means the blood is thinner than if the INR is 2. If the INR is 5, then it means the blood is too thin. The INR is 6, then we probably need to stop the warfarin. If the INR is 10, not only we need to stop the warfarin, but also we need to give some vitamin K, some antidote to the patient. Look at the half-life. 40 hours. It's very long. So if your patient is on warfarin, if you stop warfarin today, it takes a good week to remove all effects from the body, because the half-life is very long. It also takes longer to start the action. So it's very a slow medication, but very effective. The antidote is vitamin K, because it antagonizes vitamin K. So vitamin K also antagonizes warfarin. And the other thing about warfarin, I didn't mention it here, but please know that for the test purposes, you don't need to adjust the dose for renal function. So by this time, we have 2 medications that we do not need to adjust the dose per renal function. One is heparin, 2 is warfarin. These 2 medications, we don't worry about renal function. Others, we have to adjust the dose. And then the other antidote for warfarin is Kcentra. And Kcentra basically is the activated form of factors 2, 7, 9, and 10. So vitamin K is very effective, but it takes time. If you want to reverse warfarin right now, let's say the patient is on warfarin, unfortunately he or she got a motor vehicle accident, now the patient is on trauma surgery unit, and they wanted to start surgery. So they give the patient a dose or 2 doses of Kcentra, and it reverses the warfarin right away, because those are activated factors. Okay. One big consideration about warfarin is the patient needs to be educated about green vegetables, or in general, vitamin K rich foods or supplements. It doesn't mean that it's contraindicated to take vitamin K or green vegetables or salad. We want to just educate the patient to be consistent on diet. There is no contraindication in anything. But do not just have a spike in a lot of salad in one day and nothing in the rest of the week. So be consistent. If you like green vegetable, spinach, or something like that, just have it more consistently. That's the only basically dietary consideration about warfarin. And with that, we are done with anticoagulants. Now we talk about antiplatelet agents. Antiplatelets are different from anticoagulants. Anticoagulants interrupt the coagulation cascade. Antiplatelets interrupt platelet function. Totally 2 different mechanisms. Okay. One of the major and first options, first choices as antiplatelet agent would be aspirin. Okay, and aspirin mechanism of action is inhibition of COX. Do you remember what other class was also inhibit COX? COX inhibitor.
Is this the first or second one?
Is it analgesics? One of the
Analgesics, very good. Which analgesics are COX inhibitors? NSAIDs. NSAIDs. Actually, acetaminophen or Tylenol is a kind of COX inhibitor only in CNS. But whenever you're talking about systemic COX inhibitor in all body, we are talking about NSAIDs, including aspirin. A lot of clinicians or scientists, they consider aspirin as an NSAID. Some don't. But in fact, aspirin is an NSAID because it inhibits the COX, and by that, it reduces the inflammation. But at the same time, do you remember one of the major adverse effects of NSAIDs? What was that? One of the major adverse effects of NSAIDs was GI bleeding. That's why we use aspirin, because it causes the prevention of platelet aggregation. And with that, it prevents like the obstruction in the blood vessels. So besides aspirin, which is an COX inhibitor, we have other antiplatelets. They work by different mechanism of action. They work on the cell membrane on platelets and cause prevent platelet aggregation. The main ones are clopidogrel, prasugrel, and ticagrelor. Do you see them in practice? Yes. Which one do you see the most is clopidogrel. Especially the patients who have a stent or balloon procedures. You may see the combination of aspirin and clopidogrel, Plavix and aspirin together. Okay. Considerations when we are talking about dental procedure. Basically, you can read the whole slide, but there is one major point. What is the indication of antiplatelet or anticoagulant agent? And number two is how invasive is the treatment. So the more invasive the dental procedure, of course, the higher the risk of the bleeding. Okay? But at the same time, you have to consider why the patient is on aspirin. If the patient is on aspirin just because the patient wants to be on aspirin, because a lot of patients just like to go to a pharmacy and take aspirin, that's okay. You can discontinue that. But if the patient is on aspirin because his or her cardiologist puts him or her on aspirin, then we don't want to discontinue that. Okay? So for the majority, 90% or higher of dental procedures, you do not need to discontinue aspirin. For the majority of dental procedures, you do not need to discontinue anticoagulants. Because if you discontinue them, the risk is more than benefit. The risk is blood clot or MI or a stroke. Okay? But the benefit is you probably want to prevent bleeding. But the bleeding is not major for the most part. So that's something that you need to justify, a dentist needs to justify and discuss with the patient. Okay? But I don't say that for any dental procedure you shouldn't do that. There are some very invasive, very traumatic dental procedures that we need to stop anticoagulants, yes. But what I'm just saying is those are less than 10% of the cases. Okay, so on this slide, I just mentioned what I just said. So you have patients that just have a stent or like they had a balloon to open the artery, and for that reason the patient could be on aspirin and Plavix or clopidogrel. We don't want to discontinue them. If the dental procedure is emergency, we perform the procedure. If it's not emergency, we can postpone that, we postpone that. We do not discontinue antiplatelets. Because if they are there for cardiovascular reasons, we do not want to discontinue them. Okay. If you have a patient and we wanted to perform a dental procedure, the patient is on anticoagulant or antiplatelet, and we don't want to interrupt the treatment, we can use topical basically agents. Let's see, just one second, not this slide, on this slide. We can use topical hemostatic agents. These agents are basically cause blood clot locally. A good thing about these is they don't go systemically. So they just stop the bleeding locally. Kind of like local anesthetic effect. They are totally local. So tranexamic acid is one of them, and aminocaproic acid is another one. These two agents are commercially available for dental clinics. Also, there are some pharmacies that can compound it for you in different concentrations. They can make it for you as a rinse, solution, or suspension, or paste. So after you perform the procedure, the patient can put the paste or rinse the tranexamic acid solution a couple times a day, and the bleeding is minimized. These are very effective, especially if the patient needs to be on antiplatelet. You don't want to stop that, or anticoagulant like warfarin. You don't want to stop that, but you can use this. Other measures like not be abrasive after dental procedures, like minimize any traumatic, like hot liquids, anything that cause the post-surgical or post-procedure bleeding, you want to educate the patient to avoid. Rather than that, the risk is not that high. It's mostly controllable. But of course, you want to educate the patient that if bleeding happen, contact you or go to emergency. If it's a weekend or late night, don't wait. Okay, great. Any questions? You're good? Okay. I think it's the end of the week. That's okay. For next week, we have an exam. So I'm going to send you a study guide for the sessions that we already had. Just follow them, and you do very well on the test. Next week, next Thursday. And okay, for next Thursday, I just wanted to ask you, for the days that we have exam and the case, is that okay with you if you start the test and the case at 9 instead of 8? Is that okay? So you come later? Okay. So whenever we have a test and case, it's 9 instead of 8. Question?
Drive to Orange County and be there around 12:30. So do you think I can leave around 10 to drive there?
Definitely.
Yes.
Yeah, definitely. You can leave around. By 10 we are 100% done. Yeah. Sure. Another question? No question. Okay, wonderful. Thank you very much. See you next Thursday. If you have any question, let me know. Question?
So when will you give us a study guide?
A study guide by Saturday morning or Friday night. It's all in Saturday, but it's just a study.